Hello everyone and welcome back to my channel. So today's topic is about the kidney, and let's get started with the first topic, which is the cystic diseases of the kidney. Now you know that there are basically two types of cystic diseases, mainly the autosomal dominant type and the autosomal recessive type. So ADPKD and ARPKD. So let's talk about individual of this in detail. Now, first, I would like to take you through the pathogenesis so that you understand the points later on clearly. Now, what happens is that let's talk about the ADPKD first. So, basically, we have this renal tubular epithelial cell which contains a single non-motile primary cilium. So, basically, in this renal tubular epithelial cell, we have this thing which is the cilium. Each of this have this primary cilium, and this cilium has some function. What does it do? It senses the external mechanical signal because of this fluid flow. So whenever there is a fluid flow, this cilium will sense the external mechanical signal. In response to this signal, this cilia will regulate the calcium ion influx. So basically the function of cilium is to regulate the calcium ion influx. And now let's talk about some genes located in the cilium. So this cilium, the main function I've told you, it is basically regulating the calcium ion influx. That is the function of cilium. Now in this cilium we have two important genes. Number one is the PKD1 or PKD2, which is responsible for the ADPKD, and number two is the PHKD1, which is responsible for the ARPKD. Now let's talk about this one by one. So if you talk about the autosomal dominant type, then the genes responsible is PKD1 gene, which codes for polycystin 1 in chromosome 16, or PKD2, which codes for polycystin 2 in chromosome 4. Now, because of the mutations in these genes, this mechanical signal was being sensed by the cilium, after which it was regulating the calcium influx. So now this mechanical sensation will be altered, right? Because there's mutations in these genes, and you know that these genes are present in the cilium. Therefore, the cilium will not be able to function properly now, and because of that, there's going to be altered mechanical sensation of this cilia. Because of which now, as you know, that its function was to regulate the calcium influx. So there's going to be a high amount of calcium influx into this renal epithelial cells. So this, because of this high level of calcium influx, this will ultimately cause unregulated growth and differentiation of this tubular epithelial cells. It will cause unregulated cellular proliferation and fluid secretion, which will ultimately cause cyst formation and the enlargement. This is the basis for ADPKD. So now you understand, because of this calcium influx, increase in the calcium influx, there's going to be unregulated growth and differentiation of these tubular epithelial cells, which will cause unregulated cellular proliferation and fluid secretion, ultimately causing cyst formation. Now coming to the other limb, which is the PHKD1, which is present on chromosome 6, which codes for fibrocystin. Now once there is mutation in this gene, what will happen? There will be defective differentiation of collecting duct and defective biliary differentiation. So this gene is regulating two kinds of function. Number one is the differentiation of the collecting duct, and number two is biliary differentiation. So once this is affected and once there is mutation, there is going to be a defective differentiation of collecting duct, which will lead to multiple cysts in the renal cortex and medulla. And because of the defect in the biliary differentiation, multiple cysts will occur in the liver as well, which will cause hepatic fibrosis later on. So because of this collecting duct defect, renal cyst will be formed, and because of this biliary differentiation defect, there is going to be cyst in the liver, right? So there's specifically cysts in the liver in case of ARPKD, and therefore this is the basis for ARPKD. So now if you come to this particular part, all these points I have mentioned here, and here you can see this is an important, very important chart. So if you talk about the ADPKD, it is autosomal dominant. We have a large multicystic kidneys, and you know the clinical features are hematuria, flank pain, UTI, etc. And this is basically how it looks. But if you talk about the ARPKD, it is autosomal recessive, and the kidney is enlarged, but it also has hepatic fibrosis, which is not present in the ADPKD. And I told you the basis for that also. Okay, there are some other kind of cystic diseases like medullary sponge kidney, familial juvenile nephronophthisis, multicystic renal dysplasia, acquired renal cystic disease, and simple cyst. So just go through this once again, but this is basically the important part. Individuals with a polycystic kidney disease also tend to have extra renal congenital abnormalities, And if you talk about the ARPKD, then you must remember that the kidneys here are enlarged, but they have a smooth external surface. And yes, multiple small cysts are present, giving a sponge-like appearance. You must remember the genes that is involved and the chromosome that is present here. Okay, these two are the only important things. Apart from that, you also have this cystic diseases of renal medulla, in which you have medullary sponge kidney. Nephronophthisis, which I have told you about, this renal disease which is characterized by variable number of cysts in the medulla, usually concentrating on the corticomedullary junction, and the cortical interstitial damage is the cause of this eventual renal insufficiency. In this case, the kidneys are small. They have contracted granular surfaces. So the kidneys are not enlarged here. Rather, they are contracted and they show cyst mainly in the corticomedullary region. Okay. Renal neoplasms, then you must understand this is a very important topic, under which you have benign and malignant. Benign, you have renal papillary adenoma and angiomyolipoma. So angiomyolipoma is important because it is present in 25 to 50% of the patients with tuberous sclerosis. And another important benign neoplasm is the oncocytoma, which is composed of large eosinophilic cells having small round benign appearing nuclei having a large nucleoli. It is arising from the intercalated cells of the collecting duct. Important MCQ point: intercalated cells of the collecting duct. And this eosinophilic appearance is because of the increase in the mitochondria. Okay, having large number of mitochondria. In gross appearance, the tumors are tan or mahogany brown. Again, an important MCQ point: they are homogeneous and well capsulated. Again, an important point. And they have a central scar. Again, an important point. So the three important points that you need to remember in this case is: number one, arising from the intercollected cells of the collecting duct. Number two, it is having a tan or mahogany brown appearance, and it is also having a central scar. So these are the three important points to be remembered in oncocytoma. And now coming to this malignant neoplasms, in which we'll be talking about the renal cell carcinoma. There are so many different types and all the points are important. I will just take you through this chart first because these are the MCQ points over here. Now there are three basic types: clear cell, papillary and chromophobe. Clear cell arises from PCT, papillary arises from both PCT and DCT, and chromophobe arises from the collecting duct. Okay. Now in the clear cell there is a loss of the VHL gene, which is the chromosome 3P. Important MCQ point. Whereas in chromophobe you have hypodiploidy, and in papillary you have trisomy 7, 17 and loss of Y. Now clear cell में this is having a clear cytoplasm, but they also have this important point, which is the delicate vasculature. I will show you the image, but first understand this having a delicate vasculature. It is not only that the cells are clear, or rather this cytoplasm is clear. Yes, that is a point, as a feature, but along with that there is also presence of delicate vasculature to diagnose this clear cell carcinoma. The cut surface is variegated, again important point, and PAX8 is positive in this particular variant. Now in the papillary variant, AMACAR is positive, very important point. In the chromophobe you have plant-like cells, very important MCQ point. And why do we say plant-like cell? Here we have something called as the racinoid nucleus, because the nucleus is irregular, wrinkled with coarse chromatin. So racinoid nucleus or perinuclear halo, ये दोनों पॉइंट्स ही कहीं ना कहीं इंपॉर्टेंट है. तो दे कैन ईदर टेल यू अबाउट द रेजिनॉइड न्यूक्लियस और दे कैन टेल यू अबाउट द पेरिन्यूक्लियर हैलो. बोथ दिस पॉइंट्स विल पॉइंट आउट टू chromophobe carcinoma. ठीक है. And it is positive for Hill colloidal iron, positive for CK7 and CD117 and CKIT. Just to kind of recollect, can you please remember where this was present? This was also present in the GIST. If you talk about the hereditary leiomyomatosis and renal cell cancer syndrome, it is because of the mutations in the fumarate hydratase gene, which gives rise to cutaneous and uterine leiomyomata and an aggressive type of papillary carcinoma. Bird hog dube syndrome, in which the BHD gene expresses folliculin, and the symptoms you see here is fibrofolliculoma, trichodiscoma and achondrones, and a pulmonary cyst or renal tumors. So this constellation of feature is seen in this particular syndrome. Now coming to this individual points, clear cell carcinoma, as I mentioned, they have a clear to granular cytoplasm. VHL gene 3P is involved. A very important image. These cytogenetics are given over here. This can be very well asked for the MCQs. So what happens is that in this sporadic papillary carcinoma, you have the trisomy of 717, loss of Y, and a mutated or activated MET gene. In the hereditary papillary, you have a trisomy 7 and a mutated or activated MET. You don't have this loss of Y or the 17 present over here. So these are the two different types of papillary carcinoma where you see this kind of cytogenetics. Now talking about the clear cell in the sporadic one and the hereditary one, in both of these conditions you have this similar kind of cytogenetics, which is deletion of this 3p, which is loss of VHL, inactivated or mutated VHL, or hypermethylation of VHL. So basically the gene involved here is the VHL gene. Now coming to papillary carcinoma, we have already discussed about the cytogenetics. And what about this MET that we have just learned? This MET is a proto-oncogene that encodes the tyrosine kinase receptor for the hepatocyte growth factor. Okay, and this hepatocyte growth factor is called as a scatter factor, which mediates the growth, mobility, invasion of these cells. So basically, this is a MET is an oncogene, and that is why when it is kind of activated over here, it leads to cancer. Now, chromophobe carcinoma में क्या होता है? Prominent cell membrane with a pale eosinophilic cytoplasm and a halo around the nucleus. So, perinuclear halo is a characteristic feature of chromophobe carcinoma. Important MCQ point. Now, this is also a type of carcinoma which is known as the XP11 translocation carcinoma. It is present in young patients. Translocation of the TFE3 gene is involved over here. The cells consist of clear cytoplasm with a papillary architecture. Important point can be framed in the form of MCQs. Now, collecting duct or Bellini duct carcinoma is arising from the collecting ducts. The malignant cells form glands enmeshed with a prominent fibrotic stroma, typically in a medullary location. The medullary carcinoma is morphologically a similar neoplasm that is seen in patients with sickle cell trait. Now, a clear cell carcinoma, they arise from the PCT, as I mentioned before. They are bright yellow, gray, white. Yellow is because of the prominent lipid accumulation in these cells. The margins are usually sharply defined and confined within the renal capsule. They basically have a clear cytoplasm because they contain glycogen. Very important point. And these tumors have delicate branching vasculature, which I mentioned just before. Now, one of the striking characteristics of renal cell carcinoma is its tendency to invade the renal vein. Important point. Papillary carcinoma arising from the DCT mainly. They are typically hemorrhagic and cystic when large. The stroma is usually scanty but highly vascularized. The chromophobe, you know that it is composed of pale eosinophilic cells with a perinuclear halo. So basically the features are costovertebral pain, palpable mass, and hematuria. So now just look at this image. This is the clear cell type. You can see this delicate vasculature also in between, and the cells which are very clear. And number two, you can see here, this is the papillary type. You can see this papillary projections. Okay, and this foamy macrophages also you can see. This one shows you the image of the chromophobe type. So you have this eosinophilic looking cells. Some cells are clear, the others are eosinophilic. So this is having a perinuclear halo, as you can see over here, right? Racinoid nucleus is also a word which can be used in this regard. Now, a particular troublesome feature of this is that it has got a tendency to metastasize widely before giving rise to any local symptoms. The most common location are the lungs, followed by the other like bones and etc. So lungs is basically the first important, most common site of metastasis. Important question. So this is it. I hope that you have been able to get the most important points from this chapter. If you like my content, then please consider subscribing. I will meet you very soon in my next episode. Till then, take care, keep studying, and thank you for watching.